Throughout the next hour, I hope our guests can share with you their experiences and knowledge on how to care for our patients in the emergency department and also as they transition to needing inpatient care. We will touch on how to manage sick patients with potential COVID-19 in the ED and how that care might be different or enhanced during their hospital stay. It is now my pleasure to introduce our three speakers today. Dr. Andrew Arcand is a practicing emergency department physician in Markham, Ontario, and has been the ED department chief at Markham Stouffville Hospital for the past 10 years. He has seen patients and guided the hospital response through SARS, H1N1, and the COVID-19 pandemic. Dr. Ryan Luther is a specialist in general internal medicine based out of Toronto General Hospital and has recently attended on the hospital's COVID ward. His academic interest is in medical education with an interest in competency-based assessments. Dr. Katie Wiskar is an academic general internist at Vancouver General Hospital. She spent the majority of the last few months, in fact, working clinically on the CTU triage team. She has seen many COVID patients in the ED and also their post-ICU transfers when they return back to the inpatient ward. She's also part of a research group working with local health authorities to provide daily literature reviews and short podcasts on key COVID-related topics. As it is standard, Brian will bring up the slide for conflicts of interest, and I'll ask each of the speakers to review their conflicts themselves, along with saying a word of hello. Maybe we'll start with you, Andrew, and then Brian, and then Katie.
Hello, everybody. Pleasure to be involved today. And I'm online from Markham, Ontario, and I have no conflicts of interest to declare.
Thank you, Andrew. Brian, please.
Hi, everyone. Thanks for the opportunity to be here today. I'm coming from Toronto, Ontario, and I have no conflicts of interest to declare.
Thank you, Ryan. Katie, please.
Hi, everyone. Great to be here. I'm from Vancouver, and likewise, I have no conflicts of interest to declare.
Thank you. And finally, for me, I am the Associate Director here at the College of Family Physicians and a paid employee. I have a couple editorial boards that I sit on and certainly no funding from pharmaceutical industry. And we'll review the mitigation of bias slide there, Brian. And certainly this program is not funded by pharmaceutical companies, and certainly any of the recommendations here are based on the guests and certainly not a position of the college. And next slide there, Brian. Oh, sorry, I just will go back to housekeeping. And our audience today is joining us both from live webinar, either by Facebook or YouTube. In both platforms, you'll be able to participate by asking our panels questions, as with previous webinars. We invite clinicians to submit questions at any time during the webinar. For those of us that are using the YouTube, please submit your questions in the chat window. You will need to log on to your own Google or YouTube account. And finally, if you cannot see the chat window, you may be in the full screen mode. For Facebook user, if you're using Facebook, you must be logged into your Facebook account to submit questions. The chat stream will either appear to the side of your video or below the video, depending on the device you are using. And if you are watching this as a live cast, you may be eligible for a MainFlow Plus credit. In order to claim your credit, you do have to fill out a short registration form or a survey. The link will be posted in the chat or comment window at the end of the webinar, and we ask you to complete that by the end of the day on Sunday, May the 3rd, so this Sunday by 11:59 Eastern Standard Time. A recording of the webinar will be available here on the CFPC website at cfpc.ca/clinicalwebinars. And finally, for our, I do want to acknowledge the online discussion board that the CFPC has called My Groups. The CFPC COVID group now has over 4,600 physicians who share their experiences and questions, mainly in the CFPC hub space. If you do want to join this platform, and many of you will have received an invitation to join, you can create your own profile at cfpc.timebright.com. There are also 19 different specific interest group areas, such as emergency medicine and hospital medicine, that offer their own discussions on COVID-19, along with other areas of interest. So I certainly welcome you to join that platform to engage with your colleagues. We do have 2 upcoming webinars. On May the 7th, the PURE team will be reviewing emerging evidence for a selection of COVID-19 topics. And the following week, on May the 14th, we'll be revisiting the care of the elderly in long-term care homes with a webinar in French, noting that both of those times are at 12 noon Eastern Standard Time. And then we will bring up the learning objectives, I believe. And basically, the learning objectives are there for you to review. We want to describe the clinical presentation and management of patients with COVID-19 who present to the ED. We want to identify who should be considered for hospital admission, describe the clinical approach to diagnosing and managing hospitalized patients with COVID-19, and finally, identifying clinical criteria and suggest patient needs when they need critical care consultation and possible admission to the ICU. So those are the objectives that we're hoping to cover today. So without further ado, maybe we'll move straight into our questions. So I'm going to start with Andrew as the first respondent. I guess I just want to ask Andrew, and possibly I'll share this question with the rest of the speakers, is just to describe your general practice for us. You know, where are you practicing? What are you seeing? And in some ways, you know, this new normal that we're having, how has that really changed your everyday practice life, Andrew? We'll start with you.
So I'm in a busy suburban emergency department where we would typically have been seeing up to 250 to 280 patients per day. And our life, everybody's medical lives across the country in the places that we work are dramatically different. We are seeing half or less than half of our normal volumes. Obviously, with folks staying at home, we're seeing less acute injuries. And obviously our work environment is different with respect to necessity for PPE at a baseline, and then engaging with we are approaching things dramatically differently than we were 6 weeks ago. I think as we go into the room, despite our patients being, you know, met and screened as they walk in the door, and then secondarily screened at triage, we then stream them into, you know, a high risk, medium risk, low risk status. But even as we approach our lowest risk patients, most of us are very careful and cautious about making sure that we are protected as we go and engage with our patients on a day-to-day basis. Our shift length is the same, although we've adjusted our coverage as many emergency departments have. So our shifts are very, very different. It's less high paced. It's impossible to see the same numbers as we did, even though our numbers are lower. And then, you know, I think we've changed our departure piece from the department. So, you know, in the old days, you just sort of come in and come out. And now I think we're really thinking and preparing before we arrive on shift. And then as we leave, we're super cautious about making sure that, you know, as high-risk providers, we are not introducing risk unnecessarily back home to our families and loved ones.
Great, thank you, Andrew. And that's certainly a big concern is provider safety, and also to those of our families. I guess next I'll invite Katie to provide some comment. And, you know, we go from the old normal that really was just about a month ago to now, you know, a new normal. And then in your workplace, in terms of inpatient ward and as a CTU attending, what has life been like for you?
Yeah, I think things have really evolved obviously over the past 4 to 6 weeks, and they're continuing to do so. Our workflow structure likewise has changed quite a bit and continues to change. Just today we have a new ward opening, so there's been the creation of dedicated COVID units as well as a COVID pending unit. We actually now have 2 of those to kind of try to help the workflow out of emerge and try to keep both patients safe and appropriately cohorted, as well as kind of minimize staff exposure. So I think that has taken a lot of getting used to, just the workflow and staffing models as that's been rearranged. I think, like Andrew, we initially had quite low volumes. The residents were all a big fan. Call nights were a lot less busy, but we're starting to pick up and get back to our usual CT volumes. And I think that we're seeing patients present a bit sicker because they've been staying at home. So we're getting a bit back to normal there, but it's really been a month or 2 months of kind of daily evolution as our understanding of this disease has changed, as our hospital systems have changed. So it's been very interesting to live through.
Great, thank you, Katie. And I think that's a point that we'll probably pick up on later on in the show, talking about some of the sicker patients that may come to the hospital, including both the ED and also the inpatient setting. I guess Ryan, you'll be the last one to go at this round of questions. Is how has life changed for you? What's the new normal looking like for you?
Yeah, I would echo what's been said. Things are quite different than they were before, and I think one of the biggest things for us is being extremely deliberate about everything we do with regards to the PPE, and being very vigilant to have a low threshold to consider COVID in any patient, whether they have a compatible syndrome or something that may be non-specific. And that's really made us keep our guard up and be very careful with that in almost everything we do. And we've seen similar things with regards to our volumes. We had very, very low inpatient volumes for a couple of weeks, but in the last weeks, we've seen things really pick up, and we've almost doubled our inpatient census in the last week or so. And it's primarily with patients without COVID who have been waiting at home, and we are seeing a few patients who are quite sick. And I haven't seen robust data on this, but I do wonder whether some of this may be concerning as to the patients who may be coming in the doors in the next couple of days and weeks.
Thanks, Ryan. Certainly a big concern with PPE. We've heard not just in the regular media, but in our previous webinars, there's been some significant comment on stress for healthcare providers in terms of PPE. I guess we'll move straight into the clinical aspect of really diving into how to manage COVID patients and perhaps starting their journey in the ED. I think we're just might have lost Andrew. I was going to post something to him, but we will carry on, and maybe I will. Andrew might be back. Andrew, you back with us?
Yeah.
Yeah, you're back. Okay, perfect. I think what I might do is ask you, Andrew, is, when you see a patient in the emergency department, before we used to think of COVID-19 patients as purely kind of a respiratory illness. Now in some ways, it's very hard to differentiate it, isn't it? I wonder if you could give us a little flavor of when you see someone in the ED, what are you thinking of, and what's some of the important questions you're asking to kind of differentiate some of these patients and their presentations?
So bear with me, because I think the COVID question is on all of our minds. And I would start by saying that, many of our cases come in undifferentiated. So, somebody who's unconscious, an MVC, a toxic ingestion, those kinds of things aren't coming in with respiratory symptoms, but we have scenarios where we don't know these patients. So for resuscitation or a potentially critically ill person, we've presumed that everybody could be COVID positive. And that's important because it does change how you prepare, how you gather your team together. And we also think ahead to anticipate whether somebody's going to need critical care. So rather than walking into somebody who's altered, like a post-ictal patient, and expecting them to gradually, come around, I would that patient as somebody who's going to potentially decline, and I would actually start off PPE with any resuscitation and gather my team accordingly. This other subset of patients who don't need resuscitation but need assessment, we see lots of typical patients with febrile respiratory illnesses. Those ones are relatively straightforward. They're often clearly identified at triage. We've been really careful with doing a lot of histories by phone without engaging in the room for lengths of time that are unnecessary if somebody's competent to do that. So we've adjusted our practice that way. We're limiting physical exam. So if somebody's not unwell, I would be a little bit more cautious about engaging physical exam if there's some other adjuvant investigations that help me make decisions. And those are for folks who are kind of clearly at risk for COVID. There's a whole subset of people that have COVID-type symptoms that are not atypical, but slightly unusual. So folks with chest congestion or tightness, people who might be at risk for PE, but sound a little bit like they could be COVID. That's a gray zone where patients need us to come in with droplet contact, PPE, take a good history, and decide what investigations are going to kind of move us forward. So that subset of people working up, as we were previously, with precautions and in consideration of COVID. And then you kind of alluded to the other group of very atypical symptoms, and those folks are really tricky. I don't know that we're doing COVID swabs on everybody with, tummy pain and diarrhea. I'm certainly not doing swabs on folks with appendicitis, but we hear lots of anecdotal stories about atypical presentations. And I think that comes to point of care decision making with providers about what their risk is. For example, if somebody come in with GI symptoms, but they were in a work environment or a home environment that put them at risk, I might consider doing a COVID swab. Although the likelihood would be low, we know it's not zero. And then the other population of patients that are really tough are kids. So, we know that COVID in general hasn't been impacting kids in the same way that it does adults, but we hear lots of stories about very unusual presentations of children who turn out to be COVID positive. Skin changes, some Kawasaki type presentations that we're hearing about, and it's super hard to change your practice or adjust your practice based on, this information that's flowing in bits and pieces, but it's what we have. So I think that, anybody who's unwell, the pediatric population is really tough, kind of fit a pattern where COVID might be positive. Many of us are using our discretion, our clinical discretion, and testing. And I think those cases that you hear about, those unusual or atypical cases, fall to astute clinicians who've made a decision to test patients that may have not met formal criteria and have used their discretion to essentially case find with atypical presentations.
Thanks, Andrew. So it sounds a bit of a scavenger hunt in terms of trying to find the COVID-19. I mean, it sounds like initially we thought it was all kind of respiratory, but now it could really come in different forms, and that creates a certain diagnostic challenge for clinicians as well. I just want to bring Ryan here for a quick comment. I want to pick up on what you said, Andrew, is the physical exam being different, and we're hearing that some clinicians are using, whether it's baby monitors or even phones to assess patients, even though they're in the room. Is this something that you've seen happen in the inpatient ward, where your physical exam and perhaps history are being done not in a traditional way?
Yeah, so I would say when I started attending on the COVID ward, I anticipated that I would be using things like iPads and phones to communicate with patients, but I found it practically for the inpatient population quite challenging. I think part of that is because we've been caring for a lot of patients who come from long-term care, who may have cognitive impairment, and so communicating with them via those means is very, very challenging. And so I've found that I've actually had to go into the room to see most patients, at least to do a general assessment, but I've really limited my physical examination, and even in many patients omitted it altogether, as long as their vital signs are stable and there's no other concern. I found it hasn't really added very much for the majority of patients, especially if they aren't decompensating. The monitoring thing is interesting because we have done a few things with technology in that we've installed a few baby monitors in the room so that we can watch a patient more continuously from the nursing station, on a more minute-by-minute basis than someone we're worried about. And I've also installed some monitoring of vital signs and continuous oxygen saturation monitors as well on a limited basis, or even putting the monitor on the patient and then putting the screen out by the window or by the door so that someone could walk by and see it much easier without going in the room. And when it comes to the overall day-to-day management of the patients, we're being very, very careful with our orders and our investigations to try and batch things as much as possible so that the nurse or other healthcare providers only have to go into the room limited numbers of times and not have to be doing assessments every few hours kind of thing. So being very careful and choosing very carefully what tests we order, when we order them, and if they're really required.
Thanks, Ryan. So it sounds like, in some ways we're venturing into a different way of assessment too, looking at trying to protect healthcare providers and also limiting a bit of contact, both for everyone's safety and also the safety of spreading, right, I guess. So Andrew is back with us. I want to deep dive a little bit about what you were saying, Andrew, about the presentation of the COVID-19 to the emergency department. So I guess, if we take not the atypical case, let's keep it simple and keep it to the typical case of, someone coming in with a fever and respiratory illness, something like that. What are some investigations that you're ordering on this patient as you work them up? Is it any different than what you would have done previously for, let's say, a community-acquired pneumonia or something like that?
It's a good question. So we're privileged to have a COVID assessment center that's adjacent to our hospital. And so we're seeing a breadth of presentations. So our system is set up, and I suspect, although it's not the same across the country, there'll be some variability. But if somebody comes to triage with really mild symptoms, our staff will send them to the assessment clinic. So somebody coming in with a couple days of febrile respiratory illness without comorbidities, who are not remotely unwell, would get no workup and a test. And our tests are currently, our turnaround, it's varied throughout all of this. We had early on, when our province was a little backlogged, we had 3 or 4 days of turnaround, 4 or 5 days of turnaround. We're now at 24 to 36 hours. So I would argue that the vast majority of our community patients, or those who are working in a long-term care or environment staff, will come in with mild symptoms. We are swabbing some asymptomatic care providers, and then they're done. We're managing them as any viral illness. They're not sick, and we're not organizing any further investigations. Of course, we're giving them information about if tested positive, what the follow-up would be, and also if tested negative, what the follow-up would be. And that part's really interesting, such that, folks who have viral symptoms, if their COVID test is negative, we kind of advise them what to expect with a usual viral illness. But with the caveat being that we are seeing some folks who have a negative test that come back positive later. So we are retesting a subset of patients who have a persistent febrile respiratory illness 3 or 4 days later, and we're encouraging them to come back for reassessment. I would say that's kind of group number one. Group number two, we folks who look like they're having some respiratory challenges. Maybe their SATs are low, or they describe that's less than what they're used to. Those folks maybe just getting a simple check COVID or a COVID classic changes on X-ray, the kind of patchy changes, but also looking for usual pneumonia. Having tightness or chest pain, would then get a cardiogram. And then there's a subset of folks who need laboratory investigation. And those discomfort maybe sound a little bit like a PE. They might get laboratory query ACS or query PE. Folks that look sick, like let's say you had a SAT of 93%, you had a typical COVID presentation, those folks, we're going to be really careful. Go home. And in those cases, we will, and we'd send our regular CBC with some electrolytes to our clinician's discretion. We do have an order set for those who are going to be admitted, and perhaps I'll throw it over to our internal medicine colleagues to comment on some of the tests that we're doing that help us with the clinical course, but we might consider a ferritin, a CRP, and some other markers that folks are finding helpful for following inpatients.
Sounds good. Thanks, Andrew. I think we just lost your video. I guess if you turn off your video, we might get a little bit better sound from your audio. But maybe I'll turn it over to Maybe I'll turn it over to Katie. I guess, you've heard a little bit about what Andrew was saying in terms of bringing the patient in, looking at whether they're sick or not sick, right? The ones that are sick probably can go home with some instructions. And then the ones that are sick, they're working them up as essentially an undifferentiated patient with a possible COVID, right? So of course, it sounds like Andrew was suggesting that we still go through and order chest X-ray and EKG and all the regular sort of community-acquired pneumonia blood work. And then I think at the end there, he was suggesting that he would also order a CRP and potentially a ferritin. So I guess, from internal medicine perspective, you're often coming down to the ED to see the patient. What else do you think, we could do from the emergency department perspective to help you out with your work? And what do you think would be important to order at the first go around at the initial presentation?
Yeah, I think that as Andrew has said, it's really challenging because the presentations of this disease can be so varied. So I think one of the big things that we're finding is, especially because the patient population referred to internal medicine tends to be quite complicated often. They have comorbid diseases, they have heart failure, they have cancers, they have all kinds of other things. So I think, obviously keeping in mind that, all these other diseases still exist. And so making sure we're working them up appropriately for all those other conditions, I think is something that we're trying to be really cognizant of. So, still doing your exam and your history as is necessary to make sure you're not missing anything else. From a COVID specific perspective, we are ordering, I guess what we're terming kind of a COVID inflammatory panel in kind of anyone coming through eMERGE who we think may have COVID, who's getting a swab. And we are being pretty liberal with this, including patients who present with sort of GI symptoms as well as respiratory symptoms or a febrile illness. So for us, that includes a CBC with a differential, obviously, to look for lymphopenia, a D-dimer, a fibrinogen, liver enzymes to look for transaminitis, a CRP and a ferritin, as well as troponins and BNPs to look for any cardiac involvement. So that's kind of what we're doing in terms of lab work. Chest imaging, these people almost inevitably have a chest X-ray by the time they get to us. We are utilizing CT chest, not typically upfront for the diagnosis of COVID specifically. If we have any other reason to do a CT, so suspicion of pulmonary embolism or another disease process, then they would be getting those. And we're not having any trouble with our radiology department in terms of requesting those if a COVID swab is still pending. I'm a big ultrasound person, and I think perhaps we're going to talk more about that later, Victor, but we are occasionally using point of care ultrasound in these people as well. And then the other big thing, and maybe we're going to talk about this more, is doing repeat swabs. So either if they've already had a negative swab come back and eMERGE, or once they get on the ward, we're often finding that we are swabbing these people again because of the very poor sensitivity of that test.
Sounds good. Thanks, Katie. So that was a good roundup of all the things that we should be thinking about and thinking about ordering those tests early so that we can give our internal medicine colleagues a bit of a head start. Maybe I'll just quickly turn it over to Ryan. Anything further you would add to what Katie has suggested?
Not really. I think I think we're always remembering that while something may look like COVID, it may be something else, and so always remembering to keep your differential broad. And so we found other things, and it kind of goes both ways. It's something that looks like not COVID could be COVID. Something that could look like COVID may not be COVID, and so just always kind of being broad with your differential diagnosis and thinking about what's going on. We've been really seeing people who have had multiple negative swabs come back positive after, we have a patient who's had 2 negative swabs and they had a positive on their third because of persistent fevers, and they were from a long-term care facility. So, and someone who's not really responding to the alternative diagnosis and the therapy for that, if they're not improving, we have been swabbing them again and again to see if we do find it, and we have been. So that's the only thing I would add.
Thanks, Ryan. That's really important to know too, is the sensitivity of the test that you're using. And that's one of the advice that I seem to give patients too, is that they ask me if my swab is negative, does that mean that I don't have it? Well, in some ways it may mean you don't have it, but not always. So thanks for the reminder of that. Ryan. We've got Andrew back on. I'm going to turn it back to you, Andrew. So we talked a little bit about the test that we would order in the ED. Now, let's say this is the latter patient that you talked about, not the one that is well and we sent home. This is the one that's unwell and we're keeping in the ED, possibly for admission. Now, if they start to decompensate, what are some modalities do you think we can try in the ED to help them? Is this basically just managing community-acquired pneumonia, or are there different ways of managing a COVID-19 patient that you're finding that's helpful?
The most challenging scenarios, because from imminently changing outcomes, many of us feel a little bit stuck. So our sick COVID patients come in with hypoxia, to be honest, as the biggest issue. And as many of us are aware, we're a little limited. We certainly do not have the tools that we had 6 months ago at our fingertips because of the risk of aerosolization with these patients. So we start with nasal prongs for oxygenation, understanding that we prefer to have a surgical mask over a patient of that nature to try to limit droplet spread. Once you get to 6 liters on nasal prongs, that much oxygenation, we're going to be a little bit more worried. If you switch to a non-rebreather type device, we then are thinking about either a non-rebreather with a surgical mask, or preferably a non-rebreather type device with viral filters. And the two that I'm familiar with are two that are called Hyox or Tavish, and they have a viral filter that limit droplet distribution for us as staff. However, you can't run them at 100% like we used to, because you risk, again, the result of further droplet spread. So you need to, you can get them up to 10 to 15 liters if you need to. You certainly want enough oxygen to keep that reservoir bag full. But if somebody is failing oxygenation, the first thing I would say, and it's worked really well for us, is that we're asking for help for many reasons. Whether or not the emerge is the best place for these folks is a great question. So if you have capacity to move them to an intensive care area, you might do that earlier with this type of patient population than we ever have before. And then, if somebody is actively declining or decompensating from a respiratory failure perspective, and you think you're moving to a protected intubation, you need to think about where the best place to do that is for you in your facility. And obviously, we have a wide range of emergency departments around the country. So for those who have, negative pressure ICU environments, that would be ideal. Negative pressure ED environments, that would be ideal. Non-negative pressure ED environments, you want your resuscitation room. And then, the reality is they're in a community ED where your physical space is predetermined. So you just need to be very careful and cautious about these patients as they decompensate. So my preference would be to ask for help from my medicine and or ICU colleagues early, to ask for help from my anesthesia colleagues or our airway team early, so that they're aware, so that if we move to the point of a protected intubation, we do it in as safe a manner as possible. And if you're in a smaller town, how challenging these patients conceivably could be for you.
Thanks, Andrew. So it is a challenge, particularly in rural and remote areas where you might not have that many negative pressure rooms or isolation rooms. You may only have 1 or 2 in your whole ED of 6 to 8 observation rooms or something like that. So I think that presents a unique challenge. I guess I want to turn to a couple of our audience has some really good questions, and one that is certainly pertinent. Maybe I'll direct it to Katie. Is the use of non-invasive ventilation. So earlier in the course of this, we were told we shouldn't BiPAP anybody, even if you had a congestive heart failure person without COVID, you shouldn't BiPAP them or put them on CPAP. Has this changed in terms of our understanding of how to use non-invasive, and what are you seeing in your practice of this?
Yeah, I think that's a really great question. I think our practice, as you say, has evolved over the past month or so, because I think that we recognize that if we are moving straight from, as Andrew said, 6 liters of nasal prongs to intubating these people in the ICU, that very quickly we are going to not only run out of ventilators, but potentially do a lot of harm to patients, putting them on positive pressure invasive ventilation when maybe we could get away with something else. So I think that we are starting to see more high flow nasal cannula use in both possible and confirmed COVID patients, with the caveat that for confirmed COVID patients in particular, that has to be done in a high acuity setting. And I know there's controversy about whether or not high flow nasal cannula is truly aerosol generating, and I would encourage everyone to respect their individual health authority policy. For us, that is considered aerosol generating, so providers are wearing N95 masks, and it's being done in negative pressure rooms where appropriate. Kind of a similar thing for non-invasive positive pressure ventilation, so things like BiPAP. We are using that both in the emerge and in kind of high acuity units, particularly in patients in whom, there's a low to moderate pretest probability of COVID, but who may actually have congestive heart failure or COPD or another disease process that would be really responsive to non-invasive ventilation. We're also seeing that used in patients who are DNRM3, so not for intubation, not to go to the ICU, as sort of a bridge. And some patients have responded fairly well to that. Again, that is done in negative pressure rooms with aerosol appropriate PPE, so N95 masks. But we are seeing more of that in the last few weeks than we did at the beginning of this pandemic, I think.
It's a great point, Katie, because beyond the clinical indication for BiPAP and CPAP, it's important, I think, to remind viewers that to recognize the standard for their own regional health authority, right, and what their local hospital is telling them that they're able to do, because there does seem to be a lot of variation amongst different health systems on their definition of aerosolized and non-aerosolized procedures. So I'll turn over to Ryan. There was actually a follow-up question to what you were suggesting previously about testing. So I guess we had a viewer wonder, so let's say somebody tested negative in the ED for COVID and now they're admitted, but that they're from an area where there's quite a few COVID patients. What is your procedure or process for retesting? And how many days after the admission would you retest them, or would you do it right away?
So there's really no standard protocol for that, and this is where I've relied a lot on our infection control department to help us in making those decisions. It's if I think the patient might have COVID, I will test them even 48 hours after the initial test, 72 hours, or if there's been a clinical change and they're not responding to therapy, and I just starting to get that feeling that I'm missing something, then I'll have a low threshold to swab them again. Furthermore, we've seen a few of our units have outbreaks of COVID, and so if we have a patient who's been doing well on the ward and then suddenly develops a fever, I usually will swab them again, especially if they've been around other patients with COVID. But if I can't explain the syndrome very well, then I'll keep testing, and we'll keep them in droplet precautions and on our patient under investigation ward until I either have an alternative explanation, or they are improving, or we have a positive test. So but we haven't seen firm guidelines on that. I do know that when they're symptomatic, the yield on the test is higher, but we still seen a lot of false negatives. And so I from my own perspective, I would rather over test patients and have them protected and protect our employees and staff members rather than under-test and have somebody undetected on the ward. So I've had a very, very, very low threshold to retest and retest relatively frequently.
Thanks, Ryan. Perfect. And I'll go back to Andrew. So I guess in another scenario that may occur in the ED is, for example, if I'm working in a more remote location where often I'm just admitting these patients to myself, I guess I wonder, when do I need to transfer this patient? And maybe in our urban setting, when is it that we think we need to activate our ICU colleagues, right? What are things in the ED that make you think, oh gosh, like this is not going well? We gotta make sure that we get a more enhanced level of care. I think we might have lost you there, Andrew. Maybe what I'll do is I'll turn over to Katie to comment first while we're trying to get back to Andrew. I guess, Katie, if someone's admitted on the floor.
So
I think. Oh, Andrew is gone for now, so we'll get him back. But Katie, let's get you to comment first. In terms of when someone's on the ward, when do you pull the trigger? When do you think this I can't manage this in the ward? I got to get this person to ICU.
Yeah, so again, I think this is an area where often there are hospital policies that make our job a little bit easier in that sense. So for us, we have guidelines in terms of oxygen use that kind of makes it a bit of a no-brainer in terms of if someone is on 4 liters of oxygen by nasal prongs, our critical care outreach team gets involved. And if someone's on 6 liters of oxygen by nasal prongs, then that's an ICU consultation. Not to say that the patient has to be transferred to the ICU, but that they're going to be involved and come help you assess the patient. I think even in patients who aren't meeting those thresholds, it's an assessment of the individual patient and their physiology. And I think some of the things that we're thinking about are both their respiratory mechanics, so their work of breathing, their respiratory rate, tachypnea, a change in that in particular, as well as some of their imaging findings and their lab parameters. So we are doing serial testing of those inflammatory markers like their ferritin, their CRP, their D-dimer, and not so much using absolute value cutoffs, but the rate of change. So if someone all of a sudden, had a ferritin of 100 day one, and on day 2 it's 2,000, and with that they're still on only 2 liters of oxygen, but they're becoming more tachypnic, looking like they're working a bit to breathe, that would prompt us to call our ICU colleagues earlier. So I think there's no other than the kind of easy answer with oxygenation. It's a bit nuanced, but I think considering all of those things helps you. And when in doubt, I really think this is a scenario where it's always good to call for help early. I think having several people at the bedside making decisions around these patients as we continue to learn about this disease is probably the best thing.
So it sounds like there's no magic bullet for it. It's really just your clinical judgment, and then ultimately always involve your colleagues early just to get their thoughts and their opinions. Ryan, I'll turn to you. I don't think we can have a hospital and emergency department COVID webinar without asking about treatments. I think there's been lots of questions about treatment, whether it's hydroxychloroquine or azithromycin or remdesivir or all the sort of novel things that are posted and questioned. What are you finding that's useful for your patients, or any of these modalities, things that our members should really consider?
Right. So it's very difficult because we're used to our patients being able, we want to do something for patients, and someone's sick and you want to give them a drug that's going to make them better. And it's been incredibly frustrating because there really has been almost no evidence for any specific therapeutic to have shown benefit. And so from our practice, what we've been doing on our COVID ward is not giving anybody a specific COVID-specific therapy outside of a clinical trial. And we have a few trials going on here for some of the IL-6 inhibitors. I think that's the main one. But other than that, we haven't been giving anybody hydroxychloroquine or azithromycin, for example, at all, or we don't have access to remdesivir either. So it's really been supportive care for the most part, trying to correct metabolic abnormalities, limiting the amount of IV fluids that these patients receive. And we've actually been trying to run these patients more on the dry side, and I've been permitting some sort of mild hypernatremia in some cases just to keep them dry, especially as for the ones coming out of the ICU. If they start to decompensate, or if I start to see that their oxygen requirements have really increased, or I see a new infiltrate on a chest X-ray, for example, then I will often start them on antibiotics, covering for a community-acquired pneumonia. But aside from that, most patients are not on antibiotics, and only the ones who are really sick and are about to go in the ICU will be started on them, unless I see clinical evidence of a secondary bacterial infection. And I see there's some questions here about also, anticoagulation and whatnot. Making sure that all patients receive chemical DVD prophylaxis, but have not been routinely fully anticoagulating them, with this thought about it being a more prothrombotic state, unless we have confirmed evidence of a VTE somewhere, which there's prompted a lot of questions with regards to the D-dimer, and whether that's can you ignore the D-dimer or not? And we've been seeing that that's a reflection of an inflammatory state rather than a sign of a true clot, unless we had reason to believe that they actually had a clot.
Great, thanks, Ryan. So there's still, the jury's still out on some of the things, but it sounds like from what you're saying is most of it is really just supportive therapy for the most part for these patients. I think we'll find out as time goes on whether to put people on prophylaxis, antithrombotic sort of therapy might be helpful, and whether the prothrombosis is it a venous or an arterial issue, and I think the jury really is still out on that. I guess the one question that our viewers might have is, if you admitted somebody, let's say they're well, I don't want to make them the sick patient, but the well patient, how do they actually go home in some ways? So I guess, Katie, we might start with you is, I guess, of course, they're still going to have to go home and self-isolate, but when do you decide as an internist that person can clinically go home from your perspective?
I think that it's as the same criteria you would use to discharge anyone typically. So obviously they have to be off oxygen therapy. They have to be back to their functional baseline or relatively close to it. And then I think we're also using some of those lab parameters, not with set cutoffs for discharge, but wanting to see that if they previously had elevated inflammatory markers or transaminitis, that those are trending in the right direction. So I think we're using sort of a combination of that as well as their clinical status. The other thing that I think has been helpful is, I don't know if you've actually talked about it here, but kind of recognizing that this illness typically presents with the initial viral phase progressing to kind of pulmonary involvement and then that host inflammatory response. And that last phase is when patients typically get very sick, have elevated inflammatory parameters, and end up in the ICU. So if we have patients who have already come out of ICU, it's a bit more reassuring in thinking that they've already hit that peak illness severity, and we can sort of be reassured and watch their inflammatory parameters trend downwards as we're sending them home. In patients who haven't been to the ICU and we're not totally sure where they are in that disease trajectory, we're watching them a bit more closely and being a bit more sensitive to changes in their lab parameters or their imaging before we're kind of letting them go. We are trying to make sure these patients have fairly close follow-up as well. So in addition to being contacted by public health, they're getting a phone call on day 2 post-discharge from one of the general internists, and then they're being connected with a joint respirology GIM follow-up clinic, and will be seen kind of on an ongoing basis with lab work as well as follow-up imaging and PFTs, I think.
So in some ways, it's really just how clinically they look and whether they can probably go home. But it sounds like the important part of it is really good follow-up after discharge and making sure that they continue to trend better in terms of their clinical symptoms. We do have a follow-up question from one of our viewers, and maybe I'll see if, Ryan, you're able to answer that since you initially brought up the idea of using antithrombotics. I guess people are wondering, have you seen with the patients that you've had? I mean, obviously we haven't seen thousands and thousands of them, but what are some numbers that you can comment on with people getting potentially DVTs or strokes or Ps? Are there any trends that you could at least comment on in terms of this sort of thrombosis phenomenon that we're hearing about?
So we haven't seen that at all, actually. We were actually talking about this morning. We've probably seen about close to 200, I would say, inpatients at Toronto General since this started. Speaking with my colleagues, we haven't done sort of the data analysis, but none of us have seen a higher incidence of venous thromboembolism in any of our patients. We have had one patient with an intracranial hemorrhage, but they were on ECMO for a period, and so that could have been attributed to that as well. What we have seen a surprising number about, and we're actually going to start trying to research this a bit more, is a surprising amount of hypoactive delirium for these patients, which is sort of unrelated to the thrombosis thing, but that's been probably one of the most striking things we've noticed in patients who just have altered levels of consciousness in the absence of significant hypoxia or metabolic abnormalities. But with regards to the actual thrombosis risk, we haven't really seen many patients with that at all, more so than you would on a general medical ward.
And just to follow up on that, I guess, Katie, when we're talking about discharging patients, is there any benefit, do you think, discharging them on a low-dose baby aspirin? Is that something that's beneficial, or what's your advice on that?
Yeah, so we have not been doing that. We have had a few patients discharged on sort of a middling dose of a DOAC, like 10 milligrams of rivaroxaban, with the help of our hematology colleagues, patients who were thought to be very high risk for thrombosis, who had really elevated sort of hypercoagulable markers, but that has not been our routine practice to discharge people. I will say that we are treating them with a kind of slightly higher dose of VTE prophylaxis in hospital, like enoxaparin 30 BID instead of our usual 40 once a day, but we are not typically sending them home on anything.
Great, thanks, Katie. And I've got one final question before we start to wrap up. We're getting close to the top of the hour for Andrew. Luckily, you're still with us, it looks like. As we were talking about initially about some of these sicker presentations of non-COVID patients, and some people in the media would mention this sort of second wave. Thinking about from a department chief perspective and a sort of a healthcare leader, what have you been thinking about or working with your hospital to do to prepare for this second wave or quite a surge of ill patients? I think we might have lost Andrew again. Okay, so maybe I'll direct that to.
We have a couple of worries or concerns. Is that although things seem does this work better, Victor?
I think we're having trouble hearing you, Andrew. Maybe I'll just turn it over to Ryan just to have his thoughts, and then we'll give everyone some time to provide their key thoughts for us. So Ryan, maybe you could just comment on from your perspective, and I think initially at your preamble you commented on some of the more sicker presentations of non-COVID patients. What's your thinking about this going forward? Are we prepared, or what are you thinking that we could prepare for something such as that?
Yeah, so I think while the COVID volumes may plateau and maybe improve over the coming weeks, I think we're going to see, as people start to leave their houses, go visit their loved ones again, and realize, I've been short of breath for the last 3 weeks, I've been having this pain for the last month, and maybe I should get this checked out now. And it may have been a few weeks longer than they would have normally. And so we've been, in our division, been bracing for a bit of a tsunami of non-COVID illnesses that we still think is coming, and it may be starting now based on the volumes we've seen pick up in the last week or so. And so we've put in place pretty robust backup systems for physicians and allied health, for example, to prepare for that in the eventuality that it does come. And we've also put in place backup systems for COVID volumes as well if they were to spike, although the data seems to be relatively encouraging in that regard. But I do think we're going to see a persistent degree of COVID volumes for the next couple of weeks or months, because I think it will kind of rumble along with what we're seeing in the long-term care home stuff as it continues to ravage those facilities, unfortunately. But I think we're all planning for a bit of a long haul for this, and trying to be well prepared and making sure the hospital has created the capacity to deal with these. trying to beef up our outpatient capacity as much as possible and ensuring that we've got good virtual care for these patients where we can. But I do think that there will be a large volume of relatively sick patients that will come through our emergency departments and require inpatient care over the coming months.
Thanks, Ryan. So I think there's still certainly more work to be done, and this luckily it sounds like with a lot of our surge capacity we haven't had to use it yet, which I think is really encouraging for us. But certainly I think it's important for all of us to plan. You know, we are unfortunately close to the end of the hour for us. We've had such a good chat. I think there's lots of questions still, but unfortunately we're running out of time. But I do want to leave everyone with the chance to offer a couple key messages that they want family doctors to know when they're caring for COVID-19 patients, whether it be in the emergency department or in the inpatient setting. Andrew, maybe I'll start with you, but maybe you could turn off your video and just use audio. That might be a little bit easier for us to hear. If you could just give us your couple of your thoughts, Andrew.
Sure, folks. Hopefully you'll be able to hear me. Our message currently is that we do need to be careful, saying that through all this, we still have some long-term care and some residential care.
I think we're just having a bit of trouble hearing Andrew.
Sounds like you're not hearing me.
Yeah, we're having a bit of trouble, unfortunately. I mean, this is unfortunately the issue with technology sometimes. It doesn't always seem to want to work when we want it to work the most. But I'll turn it over to Ryan to comment. What are some messages that you want to leave with family doctors as they're going off the care for their patients?
So I think the first would be extra vigilant with the PPE. You know, even have somebody watch you put it on and take it off, and you know, just be extra careful with that. It's really easy to contaminate yourself, especially after a long day. And so, you know, we've been doing that very carefully. Of someone spotting me putting it on, taking it off, and create a culture of calling somebody out if they make a mistake with it in a respectful manner, obviously. Second thing is, I would say anything can be COVID, and so always consider on your differential, but also don't forget about the other things that may be going on. And third, just make sure to take care of yourself. These have been long days, at least for us, and it's important to have time off for yourselves and your loved ones, and so that's particularly important.
Absolutely. Wise advice, Ryan. And finally to Katie, we'll give you the last word there.
Yeah, I mean, I think I totally agree with everything Ryan said. I'd add, I think recognizing that the test we have right now for COVID is very imperfect, as we sort of talked about. So recognizing that it is a rule in and not a rule out test, and to continue to use your clinical judgment and consider repeat testing if you think someone has a compatible clinical picture. And then I think the other message I would say is just to recognize that our knowledge and our understanding of this disease is changing on a daily or weekly basis, and recognizing that things that we say or do this week may turn out to be wrong in a week or so. So the importance of kind of staying up to date, CME events like this, I think are so key as we continue to learn more about this disease.
Thank you, Katie. So I think we've reached the end of our time together. I want to thank Drs. Arcand, Luther, and Wiskar for taking time out of their busy schedules to be with us. We've got the slide up for the MainPro Plus credits. Just to remind everybody, to claim your MainPro Plus credits, please fill out your online survey, which will be open until the end of day on Sunday at closing at 11:59 Eastern Standard Time on May the 3rd. So that's this Sunday. The address is being made available to you in the chat windows of both Facebook and YouTube, so please direct yourself to the chat windows of those respective platforms. And if you're interested in joining our online discussion forum at CFPC to share your ideas and questions about the pandemic, please register again at the My Groups, cfpc.timebright.ca. And the future webinars are, we'll put those up on the screen. So we've got two that are coming up, like I said before. On May the 7th, we've got the COVID Pivot, the peers review of the evidence for COVID-19, that's in English. And the following week, on May the 14th at 12 noon Eastern Time, same time, is the COVID-19 Pivot, Optimizing Care for the Elderly and Long-Term Care Residents During the Pandemic. And this webinar will be hosted in French. And finally, I want to thank the members of the CFPC Planning Committee who put all these working series, webinar series, together. Mike Allen, Janice Harvey, Alan Grill, Alan Fleming, Samantha Moe, Joey Ton, Guyani Sarkis. Special thanks also to Brian Cote, who's the IT expert behind all of these productions. Thank you very much for all your time. And finally, a big thank you to all of you, our members and colleagues, for being there for your patients and also for each other during these uncertain times. And I appreciate you joining us today. Please be safe, keep well, and have a great day. Thank you.